Hello everyone. Today we will discuss Aphrodite criteria for male infertility. So let's begin. This Aphrodite criteria it is published in RBMO in 2024 and this Aphrodite criteria stands for addressing male patients with hypogonadism and or infertility owing to altered idiopathic testicular function, and it is published by Sandro Esteves. This Aphrodite criteria I will discuss under the headings of introduction, design of Aphrodite criteria, what are the goals of Aphrodite criteria, basis of criteria formation, what are the different patient groups, and take home message. So starting with the introduction, male factors they contribute about 50% of infertility cases and as a significant contributory factors in approximately 20% cases. Many men they face infertility but they don't seek medical assistance. That leads to an underestimation of its global impact. Semen quantity and quality they are typically used as measures of male fecundity, and heterogeneity in the specialist that leads to a lack of cohesive treatment strategy. So, a collaboration occurs of andrologists, reproductive urologists, and gynecologists with subspecialization in reproductive medicine and expertise in male infertility that led to the development of Aphrodite criteria. The critical drivers for its elaboration were the following questions, and these were: how can male infertility patients, mainly those with unknown causes, to explain their condition, be classified to guide therapeutical management? What is the importance of hormonal treatment for male infertility? What are the current options and outcomes or limitations of hormonal therapy? So goals of Aphrodite criteria are to record patients' phenotypes more precisely, to facilitate communication between andrologists, urologists, and ART experts, to provide suggestions for unified clinical management, to improve clinical and reproductive outcomes, to identify areas where data are lacking in published guidelines, to encourage clinical research in this area, and promote the discovery of novel pharmacological treatment options. There are 5 patient groups in this Aphrodite criteria. Group 1 is hypogonadotrophic hypogonadism. It can be congenital or acquired. Group 4 is hypergonadotrophic hypogonadism, and group 5 is unexplained infertility. So 3 groups we can easily remember. Group 1 hypogonadotrophic hypogonadism, group 4 hypergonadotrophic hypogonadism, group 5 is unexplained infertility. Then what we have to remember is group 2 and group 3. In group 2 only one parameter is abnormal, that is lower semen analysis parameters with normal hormonal profile, that is normal FSH and normal testosterone levels. In group 3 two parameters are abnormal, that is lower semen analysis parameters and reduced testosterone levels with normal FSH, right? So we'll revise it again. There are 5 patient groups. These are group 1 hypogonadotrophic hypogonadism. It can be congenital or acquired. Group 4 is hypergonadotrophic hypogonadism, that is lower semen analysis parameters, elevated FSH levels, and normal or reduced testosterone levels. Group 5 is unexplained male infertility in the context of unexplained couple infertility. Group 2, only one parameter is abnormal, that is lower semen analysis parameters, rest FSH and testosterone levels are normal. In group 3, 2 parameters are abnormal, that is lower semen analysis parameters, reduced testosterone levels with normal FSH. This Aphrodite criteria it is based on clinical parameters, semen analysis, and hormonal testing. In clinical parameters, once a male patient comes to us, we have to take the clinical history. That is, we have to ask for any concomitant diseases or malformations, cryptorchidism, onset of puberty, habitual sex life, lifestyle factors, example smoking, and any medication use. Then we have to do the physical examination. Both examination, that is general physical examination and andrological examination. In general examination, we have to focus on the body composition and obesity, because obesity is itself a recognized risk factor for hypogonadism. Then is andrological examination. We have to identify signs of hypoandrogenization, virilization, and any abnormalities in the scrotal content. Now, then comes intratesticular testosterone. This intratesticular testosterone, it acts on the last steps of the sperm maturation. Its concentration is up to 100 times higher than the serum total testosterone, and it is essential for male spermatogenesis. Next is hormone concentrations. In hormone concentrations, we have to do the hormonal workup. And in hormonal workup, in male infertility, two hormones are important. That is, we have to check the FSH and total testosterone concentration. So, serum FSH and serum total testosterone. Intratesticular testosterone, it is not routinely measured because it is an invasive procedure to know the intratesticular testosterone. So, starting with the FSH apart from the if we keep aside hypogonadotrophic hypogonadism, because what happens in hypogonadotrophic hypogonadism is there is a decrease in the FSH levels. That's why there is a decrease in the FSH that leads to decrease in the testosterone, that leads to decrease in the spermatogenesis. In other conditions, there is an inverse relationship between FSH and spermatogonial quantity. That is, if FSH is increased, then there will be a decrease in the spermatogonial quantity. Then reduced FSH, LH and testosterone concentration along with decreased testicular volume indicate hypogonadotrophic hypogonadism. And elevated FSH, that is more than 9 to 12 international unit per liter, it is linked to spermatogenic defects. That is normal FSH, but normal FSH level do not rule out such defects. Next is serum total testosterone. Serum total testosterone, it is commonly used as a substitute for intratesticular testosterone due to the invasiveness of obtaining the testicular tissue. It acts as a proxy for intratesticular testosterone. In eugonadal man, serum total testosterone levels, they are highly correlated to intratesticular testosterone. And when we give SCG injections for male infertility, then these SCG therapies impact is assessed through the changes in the circulating testosterone levels that reflect the alterations in the intratesticular testosterone. But direct comparison between serum total testosterone and intratesticular testosterone may not be correlating because of the significant differences in their concentrations. So, what is biochemical hypogonadism? Biochemical hypogonadism means serum total testosterone concentrations are below the lower reference limit. And these are the different societies that have given different values for the serum total testosterone. And on the basis of that, we have to decide which patient is having biochemical hypogonadism. But what we most commonly used is 350 as the cutoff value. So if serum total testosterone values are less than 350, then we diagnose that patient as biochemical hypogonadism. So now one by one we will discuss all the Aphrodite criteria, all the Aphrodite groups. First group is hypogonadotrophic hypogonadism. It can be acquired or congenital. So definition, it is gonadal failure that is associated with reduced gametogenesis and reduced gonadal steroid production due to the reduced gonadotropin production or action. Prevalence, it is estimated at 1.9% of azoospermic male patients and 1.6% of male infertility cases are hypogonadotrophic hypogonadism. Now discussing about the causes, congenital causes are anosmic hypogonadotrophic hypogonadism is known as Kallmann syndrome. It can be normosmic isolated hypogonadotrophic hypogonadism, also known as idiopathic HH. Acquired causes are drug use, example anabolic steroids, opioids, testosterone replacement therapy. Can be because of infections, infiltrative pituitary lesions, pituitary tumors, hyperprolactinemia, encephalic trauma, radiation, excessive exercise, substance abuse, systemic diseases, that is hemochromatosis, histiocytosis, etc. Now, diagnostic criteria, hypogonadotrophic hypogonadism means everything is low. FSH and LH reduced, testosterone concentration reduced below the lower limit of the normal range, semen analysis parameters reduced below, that is below the WHO reference limit. So what are the therapeutic options available for that are, we can give GnRH pumps or exogenous gonadotropins that contain LH activity. So SCG injections, they have LH activity, so we have to give SCG either alone or we have to combine it with FSH, that is combined with HMG, urinary FSH or recombinant FSH. It has been found that there is a significant improvement in spermatogenesis to varying degrees in up to 90% of patients. So it is beneficial. So if it is an acquired case of hypogonadotrophic hypogonadism, then SCG monotherapy is usually sufficient. We have to give it in a dose of 1000 to 2500 international unit twice weekly for 8 to 12 weeks, and it increases the intratesticular testosterone concentrations. It can restore the spermatogenesis in adult onset HH. If it's a congenital one, or if adult one is not responding, then we can give combination therapy, that is SCG plus FSH. FSH in form of HMG, recombinant FSH or urinary FSH. SCG 1000 to 2500 international unit, FSH in a dose of 150 to 300 international unit. SCG we have to give twice weekly for 8 to 12 weeks. FSH we have to give 2 or 3 times weekly for up to 18 months. And it is for patients with congenital or adult onset HH that lack adequate endogenous FSH concentration, and it has been shown to achieve better therapeutic efficacy than SCG alone. Now we have to, after giving this therapy, we have to monitor the patient. So monitoring of hormonal analysis and semen analysis parameters during treatment is best. Once patient responds to therapy, it's better that we should advise patient to do the sperm banking. Next Aphrodite group is lowered semen analysis parameter. Only one is abnormal, that is lowered semen analysis parameters, and hormonal profile is absolutely normal. Normal serum FSH, normal testosterone, serum total testosterone. Definition is patients with idiopathic male infertility characterized by abnormal semen analysis, but there is no history of disease that affect fertility. Physical examination and laboratory tests are normal. Prevalence, it is estimated to range from 15 to 60% of patients undergoing infertility evaluation. Now, how this infertility is occurring? Lowered semen analysis parameters, but FSH and testosterone levels are normal. So its potential mechanism is, it is speculated to have relative hypogonadism due to reduced gonadotropin action. So maybe these FSH and testosterone levels are normal, but potential mechanism is maybe these are not acting. That leads to relative hypogonadism, so leading to insufficient spermatogenesis despite normal hormone levels. FSH activity depends on the amount of circulating FSH, its glycosylation, and the genetically determined expression levels and the function of the FSH receptor. So reduced FSH activity, it can cause it can be because of the genetic variations that affect the FSH transcriptional activity and FSH receptor sensitivity. Next is, there are single nucleotide variations in the FSHB gene promoter and FSHR gene that affect the serum FSH concentrations and spermatogenesis. And there are carriers of specific alleles that may cause inadequate FSH upregulation and spermatogenesis. So these are the single nucleotide variations within the FSHB and FSHR genes that can impact the FSH activity. They can influence the sperm parameters and can affect the spermatogenesis. So if we talk about the treatment options, then empirical hormonal therapy for such patients is gonadotropins, particularly FSH. These exogenous gonadotropins, such as FSH, they may compensate for the insufficient action of the endogenous gonadotropins, or they can stimulate the weak spermatogenesis activity. Studies suggest that there is an increased sperm concentration, decreased sperm fragmentation, DNA fragmentation, and improved pregnancy rates with FSH therapy. Meta-analysis indicates significant improvements in semen analysis parameters and pregnancy rates with FSH therapy. And dosage typically range between 150 to 300 international unit every other day. But large-scale, well-designed studies are needed to confirm the utility of hormonal therapy, especially in non-obstructive azoospermia patients. Now, if we talk about alternative therapeutic modalities, then we have SERM, that is selective estrogen receptor modulator, clomiphene, and aromatase inhibitors, that is letrozole and anastrozole. These drugs, it has been shown to improve sperm concentration, total sperm count, serum LH, FSH, testosterone concentration, testosterone to estradiol ratio. But if we talk about letrozole, but that there is no superiority over SERM and SCGs there. Third group is two things are abnormal, that is semen analysis parameters are lowered, testosterone levels are lowered, but FSH is normal. Definition is gonadal failure associated with reduced spermatogenesis and reduced gonadal steroid production due to reduced gonadotropin action. Prevalence is around 20% of the total idiopathic male infertility population treated with hormonal therapy. This is the genetic background, and it has been suggested that the response to FSH therapy might depend on the genetic background of the affected man. So these are the genetic background that can affect the response to the FSH therapy, and it has been shown in many studies. Now for Aphrodite group 3, what they have suggested as treatment options are hormonal therapy with gonadotropins containing both FSH and LH activity. Real world data suggests improved sperm quality and pregnancy rates with FSH therapy in idiopathic infertility. Studies indicate there is a positive relationship between testosterone concentration and successful sperm retrieval in non-obstructive azoospermia patients. Patients with either biochemical hypogonadism or histopathology showing maturation arrest or hypospermatogenesis, they are the best candidates for hormonal therapy. So what we can give as treatment is we can give FSH plus minus SCG subcutaneously 2 or 3 times a week, varying doses titrated to keep the endogenous FSH and testosterone concentrations at optimum levels. We have to give it for 3 months or longer, and it has been shown that we can get successful sperm retrieval in patients with NOA and return of spermatozoa to the ejaculate in these patients. Clinical implication is even patients with a proven genetic cause of non-obstructive azoospermia could be candidates for gonadotropin therapy because they may still have some tubules with normal spermatogenesis as occurs in Klinefelter syndrome. Group 4 is hypergonadotropic hypergonadism. Hypergonadotropic hypogonadism. So definition is patients with lowered semen analysis parameters, elevated FSH and reduced or normal testosterone concentrations, and most patients in this group are non-obstructive azoospermia patients with hypergonadotropic hypogonadism, and its prevalence is up to 10%. Its potential mechanism is in non-obstructive azoospermia males with elevated FSH and LH, these endogenous gonadotropins, they might be ineffective in stimulating the Leydig and Sertoli cells. So about half of these patients, they have low concentration of circulating testosterone also, that indicate concurrent Leydig cell insufficiency. And when we give gonadotropin therapy using SCG and FSH, they can promote spermatogonial proliferation and DNA synthesis in these patients and can increase intratesticular testosterone concentrations. Treatment options are we can give gonadotropin therapy using SCG and FSH. They have shown to stimulate Sertoli and Leydig cells. They provide an extra stimulus to the few tubules that contain proliferating spermatogonia. But some studies suggest improved success in retrieving spermatozoa from hypergonadotropic hypogonadal non-obstructive azoospermia patients who underwent hormonal therapy before sperm retrieval. But although evidence is limited and mainly from the small retrospective cohorts and case series. Next group is unexplained male infertility. Now, Group 5 is unexplained male infertility. So definition is man with normal hormonal parameters and normal semen analysis parameters, having no history of diseases that can affect the fertility, normal findings on physical examination and laboratory tests including genetic analysis. Prevalence is 15% of couples presenting with unexplained infertility and unexplained male infertility 27%. Treatment Currently, these patients are not individually treated since alterations are not detected in semen analysis or in the reproductive hormonal profile. In such cases, in unexplained couple infertility, what we treat only female partners in the context of unexplained infertility with various ART methods like low dose ovarian stimulation, IUI, or high dose ovarian stimulation in the context of ART treatment. However, these male patients could benefit from FSH stimulation if a stimulatory rather than substitutive therapeutic approach is applied. So, just like we are stimulating females, we can also stimulate males. Trials of higher FSH doses over longer periods may be warranted to explore this testicular overstimulation approach. FSH stimulation could be considered similar to ovarian stimulation in females with the goal of increasing sperm quality or quantity to enhance the pregnancy rates and reduce time to live birth. If we talk about its safety considerations, then while ovarian stimulation in females can lead to side effects such as OHSS, minimal to no side effects have been reported in studies using FSH stimulation for male patients with idiopathic oligospermia. And despite the hypothetical risk, evidence from the studies that involve FSH stimulation in men with having high FSH concentration and those with FSH secreting pituitary tumors, they suggest potential efficacy and safety in improving spermatogenesis. So overall, Aphrodite criteria treatment objectives are to improve semen parameters for natural conception and to enhance semen quantity or quality for ART treatment. This is Aphrodite criteria, 5 groups in a nutshell. So what is Aphrodite criteria? It's a novel stratification system for infertile men with testicular dysfunction for whom fertility prospects may improve after hormonal therapy. It is based on routine clinical history of physical examination, semen analysis parameters, FSH and testosterone profile. These are the groups, group 1, 2, 3, 4 and 5 that we have discussed. Now, if we do SWOT analysis for Aphrodite criteria, that is, if we look at its strengths, weaknesses, its opportunities and threats, then strengths are standardization of diagnosis, it improves decision making, potential for personalization, it is evidence based. If we look at its weaknesses, then it limited generalizability, its rigidity, potential for overdiagnosis and its complexity. Opportunities are integration with new technologies, further research, we can do global adoption is there, enhanced patient counseling. Threats are there is a rapid technological changes are going on, diverse population variability is there, competing framework is there and regulatory barriers. So take home message is current guidelines recommend investigating both partners in infertility cases, but reliance on semen analysis often leads to neglect of further investigation. So if we are getting any abnormality in semen analysis, we should investigate male patients. And we should not rely only on semen analysis for male patients. Aphrodite criteria aim to address the deficits by considering clinical parameters, semen analysis parameters and hormonal levels for their comprehensive assessment. Extended investigations into infertility causative factors, they can enhance ART efficiency and they can reduce the costs. Hormonal therapy that are guided by the Aphrodite criteria, it may enable man to achieve biological fatherhood through various ART techniques. However, current hormonal treatment options, they often lack precision due to empirical approaches rather than precise patient classification. Thank you.